So we're still covering the combining forms for uterus, and we just finished with hysterosalpingo-oophorectomy, and we're kind of taking a bit of a pause before we move on to the next combining form, because I wanted to talk about a different type of pathology. Remarkably enough, for this class, this is a benign pathology, and we don't, it seems like we often cover such heavy and dark pathologies. It's nice to have one that's kind of benign. This is called a leiomyoma. In other words, a fibroid tumor, often referred to as simply fibroids. These are benign tumors that start in the uterus. They are the most common tumors to be found in female anatomy. If they grow too large, they can cause pelvic pain, menorrhagia. In that case, a hysterectomy may be indicated. Typically, for this type of pathology, insurance companies will not pay for a hysterectomy. They will pay for pain management. However, some patients will go ahead and opt to do it. I had a good friend in her early 30s who was bothered by fibroids and had just caused dyspareunia and other symptoms that were very unpleasant. So she went ahead and paid for a hysterectomy out of her own pocket because insurance wouldn't do it. She took a loan out because to her it was important to alleviate herself of this pain, and since that day it's been gone. So she was able to facilitate that herself. Most of us can't do that, unfortunately, because of the expense. So it's nice to know these are benign. However, they can result in kind of a serious surgery if it gets bad enough and if the doctor and the patient both feel it's a feasible option. Okay, so let's get back to our combining forms to uterus. We have another one called metro. This also means uterus. And in this case, we're referring to the endometrium. So take a look at that word, endo meaning within and meaning structure. So endometrium is a membrane that lines the uterus. I'd mentioned that lining earlier as being the lining that grows every month in the female uterus, and it becomes a sort of fertile place for an egg to be placed. So the endometrium itself provides that fertile environment for that ovum to survive in, and so the ovum will implant into the endometrium, and then of course during menses, when the uterus sheds the entire endometrium. So sometimes tissue is involved with that. Of course, the ovum comes with it, and of course, there's the blood also associated with the monthly menses, and so that's our term endometrium. Endometritis is inflammation of the endometrium. Once again, endo meaning within, meter uterus, and itis being inflammation. So that's a form of inflammation. It may be a symptom that's associated with endometriosis, which is presence of endometrial tissue outside of the uterine cavity, such as in the pelvic or abdominal cavity. So in this case, the endometrium has somehow proliferated and its growth is extended beyond the uterus itself, and it's now involving the outlying structures. You see endometriosis here depicted on the left and normal uterus depicted on the right. So you can kind of see what they're illustrating here is that tissue that would be normally contained entirely within the uterus has now spread to the area surrounding it. Causes some complications and can cause some procedures that are necessary to correct it. We have another term, cervico, and this is specifically the cervix uteri. So when we describe the cervix uteri, we're being specific to the uterus. Cervix in and of itself means neck. And so if you ever heard an orthopedist or maybe in a different practice of medicine, they talked about damage to the cervical spine, they're talking about your neck, the 5 or 7 vertebrae that support the neck. So you have more than one cervix in your body because you have more than one neck. There are other organs that have necks on them. The gallbladder is one of them. And of course, we have the skeletal aspect. So we have the cervical spine. In this particular case, we're referring directly to the uterus, hence the term cervix uteri, the neck of the uterus, if you will. So cervical, once again, can pertain to the spine. In this case, it's pertaining to the cervix uteri, which is the neck that's extended from the cervix. And cervicitis is inflammation of the cervix uteri. One thing I want you to note here, and this will come into play a little bit later when we talk about the different type of pathology. If you look at the area defined as cervix here, you have an internal os and an external os. And those os simply means opening. And so those are simply openings. And there's a very thick muscle wall between there. And of course, that's designed for a specific purpose. And that's why there are two entrance points, if you will. They're all consecutive and within the same within the same lumen, but two different sphincter muscles at work there. So looking at it in this case, this is what the spermatozoa, when they're released into the vaginal canal during ejaculation, have to make it through the external and the internal os and then into the uterus in order to fertilize the egg. Sounds complicated. It's much more easily accomplished than you might think. Okay. Now we're going to move down the structure. So we started at the ovaries, we followed the fallopian tubes around to the uterus, we then descended down into the cervix, and beyond the cervix we have the structure known as the vagina or the vaginal canal, two combining forms, vagino and colpo. So using the term vagino, we have vagina, as in vaginal, pertaining to the vagina. Vaginitis is inflammation of a vagina, and vaginodynia would be pain in the vagina. And the other term we have for vagina is colpal, and we see that illustrated here. And it's primarily used around the term the colposcope, which is an instrument to examine the vagina and the cervix, and a colposcopy, which is the visual examination of the vagina and the cervix. This is a procedure I used to assist on quite a bit in one of the practices I worked at. So what I would do is stand next to the patient while the doctor was at the foot of the table doing the procedure, and I would often provide comfort to the patient during the procedure, and then of course I would help collect the specimen. Essentially what happens is they use the speculum to hold the vaginal canal open, much like they would in a pap smear. And for those of you who don't know what a speculum is, we'll cover that a little bit later in the lecture. So the vaginal canal is held open, the scope is inserted, they look at the cervix. What they're looking for is any indication of cervical cancer or cervical dysplasia. One of the tricks I saw that really surprised me the first time I saw a colposcopy was that the doctor had a spray bottle of vinegar and she sprayed it through the vaginal canal onto the cervix, which the first time I saw kind of alarmed me. I'm like, what exactly is this all about? Then she showed me in the scope, and this was very interesting because the area of dysplasia, in other words, the area where we saw the abnormal cells, and by the way, the abnormal cells are typically found on a pap smear. So an abnormal result comes back from a pap smear, which is the cell looking at the cells of the cervix, and they're abnormal. And so the doctor says, okay, now we need to take a physical look at it, and hence the colposcopy. So getting back to the procedure, she had a spray bottle of vinegar. She sprayed it through the vaginal canal onto the cervix. And the interesting thing was the vinegar would cause the dysplastic cells, the abnormal cells, to blanch or to turn white. And once that happened, she knew exactly where to take the specimens, right in the middle of those little white areas. So that was a really interesting trick that I learned. They have the biopsy forceps you see here, and while the vaginal canal is still held open, and they find the areas of it's either erythema, so it's going to be red, or they're going to spray the vinegar on it and it blanches them white, and they're going to pinch off little pieces of that tissue. We collect them in formalin, send them off to the lab, and see what there is to see. Hopefully it comes back that there is no pathology, but of course we do this to make sure that there's no pathology. Abnormal pap smears sometimes happen, and there's no evidence to follow up, and other times there is. So if you're ordered for this procedure or you're involved in it, just be aware that's what's going on. It's a screening process to make sure there's no further concerns. And of course, recto, we've had this before in the digestive chapter, so we won't go into a lot of detail. There's a new term here, rectovaginal. This is pertaining to the rectum and vagina. Given the female anatomy and the close proximity, that is a pathology and a potential place of pathology, and a word that's often used to describe those pathologies. A rectocele would be a herniation of the rectum into the vaginal canal, and we see a depiction of that here. You see the rectocele here, and it's kind of pushing up in that diagram on the bottom to the right. That rectocele is pushing up against that uterus and making it sort of difficult for it to be placed where it should be. It's displacing it. So that's a herniation that would have to be looked at, not to mention the fact that's going to affect the GI tract as well. Okay, now we're moving on to the breast. And we have, as you can see, two combining forms for breasts, mamo and masto, and two combining forms for milk, galacto and lacto. So we're going to start with the breast combining forms. Mamo or masto are used to combine the form mammary, which would be pertaining to the breast. Mammography is an X-ray examination of the breast, and a mammogram is the X-ray of the breast itself. So we often call this entire procedure a mammo, and we just leave it at that. Everybody at this point in time knows what we mean when we use the term mammo. So they're not going to often say they're going to order mammography or say we're going to order a mammo for you and you'll have to report, so on and so forth. This is a very basic depiction of how we do this in radiology. It's a specified type of exam that we do. I've often had the question, well, if you're trying to prevent cancer, but you're using radiation, and what you have to know in modern radiology, and very much so in dental and also in mammograms, that it's a very, very, very low dose of radiation. It's extremely it's well within the safety margins for anything that might occur as a result of exposure to radiology. So it's very low dose and it is very effective. And of course, mammograms are something at a certain age you want to start paying attention to, or with the use of HRT. Usually after the age of 50, most doctors will have you get at least one mammogram. Depending on those results, we may ask a patient to come back and do them yearly or every 6 months, or in some cases, we'll see you in 5 years. So it really kind of depends on the patient and the history, and more importantly, the family history. Because like prostate cancer, breast cancer is hereditary. So if you have a first-degree relative, a mother or a sister who have breast cancer, that patient is in itself, they are at risk of breast cancer. So it's definitely an indication for a mammogram. If a mass is found, sometimes in the casual language, it's called a lump. And in the old days, they would do a different type of procedure that would remove the entire breast. But in modern medicine, they do something called a lumpectomy. So this is the most common form of breast cancer surgery. Instead of taking the entire breast, they just take the primary tumor. So our technology is to the point where we can isolate the tumor, see exactly where it is using ultrasound and mammography, and then can remove it. They take some of the normal tissue around it, because anytime you remove a tumor, you want something that's called a clean margin on the specimen, or a clear margin. And a clear margin means there's no cancer outside of that specimen that you take, which means that you took the specimen and healthy tissue around it, which is another way of saying we got all of it. And it's what you want to hear, clear margins. So yeah, they do take a small amount of normal tissue around it and hopefully they get it all. If margins are not clear, it usually means they have to go in and do another excision until they get all of it out. So that's the reason they take normal tissue around it. Sometimes lymph nodes are removed, and we do that because cancer can spread through lymph nodes. And there are a lot of lymph nodes in the axillary region and in the breast region. And of course, then they do a biopsy to determine if cancer cells are present in the normal tissue surrounding the tumor. So there's all kinds of caveats with lumpectomies. But most of the time, they're very effective in removing the cancerous or the dangerous element without taking excessive amounts of tissue. Now, mastectomy is different than that. This is a complete excision of the breast. And when they say complete or partial, by partial they mean they may leave some of the base of the breast in place, but for most part, the entire breast is going to be removed. This is most commonly performed to remove a malignant tumor, which is true depending on the state of the tumor, what its stage is, what its aggressiveness is. There's all kinds of things that go into it. So a mastectomy in the old school, let's go back 50 years, would be any form of breast cancer. They would have taken the entire breast and the lymph nodes. In this particular case, and in modern medicine, mastectomies are usually more of a radical thing. So they're not as likely to take the entire breast unless there's really good reason to think that the entire breast might be a threat to the person's long-term health in terms of metastasizing. So in this case, this would be a more advanced form of cancer. It'd be a more aggressive form of cancer, and they're taking the lymph nodes too, so there is no chance that any cancer can spread from that. And of course, in association with cancer, there's always something, there's always a course, not always, but typically a course of something called chemotherapy. Chemo meaning chemical, therapy meaning treatment. Chemotherapy is the treatment of cancer using chemicals or drugs. It's very hard on a patient to go through chemotherapy. It has devastating effects on the body. Modern medicine is getting a lot better with certain forms of cancer. We can identify the cells. In fact, some of the research that's going on right now, they have found that certain types of cancer can be treated by using your own immune system. They remove some of the T cells from your body, and T cells fight infection. They introduce it with the type of cells that are present in the cancer in your body. They train the T cells how to attack it and put the T cells back in the body and let the immune system take care of it. So eventually we hope cancer therapy gets to that for everyone. For right now, it works for certain types of cancers. It's cutting edge technology, but it's really exciting. And it could do away with chemotherapy almost entirely. That's my 15 minutes.